So for the first panel, oops. So I want to ask first, Sabrina, what do family members need to be aware of when it comes to advance directives and things like that?
Hi, my name is Sabrina, and I'm just a little bit of a background. I'm a critical care nurse at PIH.
I should have probably, as the host, should probably introduce everybody, huh? Let me do that real quick. To my left, hi, Dr. Ma. This is Dr. Lisa Ma from Mosaic, right? And next to her is Nina Solace from PIH Whittier, and you're a nurse navigator for oncology, right? Nina was fantastic with us when we brought care bags, and we got to know her a little bit, and she's just really great. So we're glad you're here. Sabrina, of course, Sabrina Vasquez is a critical care nurse, PIH, and just all around great person. we loved hanging out and talking to her. And then next to her is somebody you probably don't know. No, I'm just kidding. This is Cynthia Liu. She's our pastor's wife, and and our pastor's clapping for. But what's really cool is she's also a hospice or retired hospice nurse, and so very, very important, very special to this group as well. And then Dr. Shum, the one that I should have actually chosen to be at PIH with. I loved what you said earlier. It's great. Okay, now let's go back into you. So what is it that family members need to know, and what is it that the patients need to be able to communicate to the family members when it comes to things like advanced directives?
I think one of the most important thing is that they learn to communicate with each other. It can be a very difficult and touching subject, especially if it's cultural, or if the patient, whether it be the husband or whoever it is, they just don't want to talk about it, or the wife that doesn't want to involve the rest of the family because it's just her problem. So what happens is once they come into the hospital, whatever brought them in, if they wind up in our unit in the ICU, we find that unfortunately I've had an opportunity to sit in many family meetings. I've been a nurse for in the critical care for 14 years, and a lot of questions are asked, especially if they're end of life. And one of the things that we ask is, what did they want? Do you have an advanced directive? Do you have a pulse? And we'll go over some of those, which is a physician-ordered life-sustaining treatment plan. And a lot of times we hear no, and it's because they don't want to bring up a very touchy subject. And it is very difficult to talk about, but you can see the distress on the family's faces when they haven't gone through that, because things have come up so fast. And to some degree, even unexpectedly. But now we're in a situation, and now it's putting a lot of weight on that spouse, on that family, for their loved one, in having to make these decisions when they should have, at some point, maybe had that difficult talk and asked them, what would you like? And what do you see as being a quality of life versus what family sees a quality of life for them? Because it might be quite eye-opening when they actually ask their loved one. In doing a little bit of research for some of these advanced directives, there was a couple of them that I actually had liked, but I just wanted to go into, before I go into these advanced directives, if you hear some of these terms in healthcare, I want you to have a better understanding, because these medical terms will empower you. So we're here to just educate you, empower you in the things that you hear, that you learn, because we don't want you to be caught off guard. So when you go into the hospital, you're seen as a full code. Full code means everybody is a full code when they come in, meaning that we are there to provide any heroic measures. They're to do compressions. If the person should become unconscious and they are not able to breathe for themselves, we are doing compressions. We are doing CPR. We are intubating. So intubation means we are putting in life support. We're putting a tube into their mouth and we're actually breathing for them through a ventilator. We're giving them emergency drugs. That would be anything that is going to help them in supporting them during that time. Maybe bringing up their blood pressure or giving them, it's called epinephrine. It's something that we already have in our system, but we're giving them more of that. Just again to help them regain a heartbeat. So we're shocking them. Okay, so those are all the things that we're doing for them. For if you're a full code, we're providing all of that. And if things aren't going well, the physicians may even bring up, they don't even have to be good, not going well, but sometimes patients do this themselves. They'll bring up what's called a do not resuscitate. A do not resuscitate, or a DNR, means if my heart should stop, I don't want you to resuscitate me. I just want you to support me in the process of passing. And do not resuscitate means not only will I not do compressions, but we're also not going to put the tube down into the throat. We're not going to support them on a ventilator as well. Or give those emergency drugs, because at that point now we're just prolonging what's coming, and that would be they're in the process of passing. So when they've decided that, that doesn't mean that we don't treat them. Okay, so there's a misconception, and we asked some of our family members, what is the misconception from you going from one to another? And the misconception is that we're kind of giving up on them, when we're not. We're still providing antibiotics. We're still providing medications that might bring up their blood pressure. We're still providing things. But I think the question needs to be asked is, what does it mean for them? What are we going to be doing if they're made a do not resuscitate or a DNR? There was one patient, and she was very adamant with her family that she did not want to be resuscitated. She had DNR tattooed on her chest.
Oh, wow.
So when you go and take off the shirt, it's on there. And that's her.
Interesting.
Right? Hands off. So she was speaking for herself. Okay. And then the last step. So again, there's 3 steps: the full code, all heroic measures. The DNR is again providing resuscitative measures to some degree, unless the heart should stop or if they have difficulty breathing. At that point, we're not intubating them. And then the last one is comfort care. So comfort care is, at that point, we're making them comfortable. We know that we're at the end stage. We already recognize that they're in the process of passing. So at this point, we are just going to do just that. If they are intubated, we will make them extremely comfortable to the point of almost going into a sleep. So morphine drip is usually placed on that patient, because we don't want them to feel any form of discomfort while they're in the process of passing. Also, usually at the end stage, they have this breathing pattern that we don't want them to go into. That it's not comfortable. We stop taking a blood pressure, because a blood pressure every 15 minutes is not comfortable. So we just kind of help them through that process. So in that sense, once they're comfortable, we take out the intubation tube, and we allow them to pass naturally, and in that process, and that's comfort care.
So can I ask you a question?
Yes.
So you have some materials there that deal with this, right? And one of them was the 5 wishes.
Yes, so 5 wishes. So one of the social workers have given me this, and 5 wishes is just check boxes in the sense of like it's a form of an advance directive, and it just says on one of the wishes is you have to be able to answer all these wishes in order to make this directive. And it says the person I want to make care decisions for me when I can't. The second wish is the kind of medical treatment I want or don't want. The third is how comfortable I want to be. The fourth is how I want people to treat me. And 5 is what I want my loved ones to know. And there's actually in the back of this, and I'll leave these out in the front so everyone
Yeah.
can see them. As to it, actually, it's very eye opening in that sense, and it helps to start the conversation. The next one is a physician is a pulse. I think Dr. Shum, do you provide pulse?
I mean, most hospitals will have those same forms.
Okay.
And so I think it does simplify it, to not do chest compressions or mechanical intubation.
So in this sense, it tells that there's check boxes. You go over it with your physician, and there's check boxes. It comes in pink, so that way, if for any reason it's lost or it's in a shocking pink in the sense of like it's easy to find, and you can give it to the healthcare personnel, and it tells us exactly what kind of treatment you want. The next one would be the California Advanced Healthcare Directive. In some cases, this will, along with other information on directives, helps others make that choice for you should you become, they call it incapacitated, you're not able to make the decision for yourself. But you want to choose somebody that is really going to be your voice when you can't. And that is extremely important. And I can't stress that enough. They have to be able to, as difficult as the situation may be, they have to be able to follow your wishes, being your voice when that person is not able to.
That's awesome.
Oh, I just wanted to mention something. So my name is Dr. Lisa Ma, and I have a family medicine practice in East Los Angeles for the past 24 years. So I see patients right when I first see them, and when they become my patient. If they're 18 or older, I actually do the pulse form with them, especially nowadays. I have a friend whose son was in a car accident, and he was in the hospital, and his father couldn't even get any information on him. I know that sounds crazy. But that's the reality now. So I try to get all my patients to have a pulse. So if you don't have a pulse, please talk to your physician and get a pulse to have in your primary care doctor's office. And sometimes when something happens, they'll call me because my name is on there, and they ask what were their wishes. I have them give it to their loved ones who they choose. Now, I don't force them to write it right away because oftentimes they're not ready for that. But actually, I would say 9 out of 10, they're filling that out. And they say, oh, I already know what I want. And just there's about 1 out of 10, they're like, they don't even want to talk about it. And so I say, just take it home, start the conversation. And then the 5 wishes it's amazing. I feel like it's opposite of it is like a birth plan, for your baby. You want everything. You want to have your essential oils. You want to have massage. You want to have music. And which music do you want to play? And it's really beautiful. And we also pass that out to our patients. Definitely all of our seniors get one during admission, and we check on it, and we check every year to make sure it's the same, because it changes. I've had patients who've lost the person who's their decision maker before them, and they were surprised, but and so they had to choose another decision maker.
I was going to say, it takes the burden away from the family member now having to go through this, because their loved one is spoken to you and through the paper.
Yeah, so I was thinking the same thing from a patient perspective. For me, it's really scary sometimes to do this because I don't want to make that decision because I don't want, like you said, I don't want them to give up. But it's not giving up. It's actually just making sure that you can lift the burden because somebody's going to make that decision. And so if you can make the decision, that's the best. So that's why I wanted to start off with this, because this is a topic that every single cancer patient deals with. Every single one of us deal with. We have this in our minds. And so thank you very much for doing that. Do any of you deal with lupus at all? Because there's a question, what long-term solutions are being done to help lupus patients and their symptoms? And is there any kind of gene therapy or anything ideal to help lupus?
I can kind of comment a little bit about that. Most of the lupus medications are like chemotherapy. What may be coming on the horizon, I sit on a board in New York, and they're working on some of the immunotherapy treatments that are being used in cancer right now called CAR T-cell. And I hear through the grapevine that they're going to try and do this overlap immune therapy into the rheumatology space, where lupus would be one of the diseases that may be a candidate, as well as for some of the neurologic diseases. So kind of stay tuned. I'm not a rheumatologist, but I sit on a board for another committee, and they've been talking about CAR T-cell therapy, which is immune therapy that we use in cancers to see if it also can control the immune-driven mechanism from underlying lupus.
That'd be great.
Oh, yeah, sorry. So actually, I treat a lot of lupus patients. I'm usually, since I'm the primary doctor, I'm usually the one who, gets that first ANA, anti-nuclear antibody test. And so I'll tell you of a few patients that I've had recently. I'm part of a group of physicians that believe that the human body is not really attacking itself. So we tend to not call it autoimmune, although we do know that it is attacking that cell. But we feel that the cells and the body was designed to protect itself. So it is trying to attack that cell because it has something in it. So oftentimes what I'll do is I will do a panel of toxin testing and also Lyme testing. Unfortunately, the Lyme testing that's done in Quest and LabCorp, which most people have, is pretty insufficient. It only tests for maybe 1 or 2 species of Lyme. And so I sometimes, if my Medicare patients, my straight Medicare patients can get tested by laboratory, IgeneX, that tests 16 plus species of Borrelia, which is Lyme, Bartonella and Babesia. Those are intracellular organisms, Ehrlichia and Anaplasma. So oftentimes I will find a patient, they come in, they're like having their joint pain and they have their ANA positive, I check their Lyme testing, and sure enough, they have like 1, 2, or all 3 of the bacteria. So I will treat them with supportive care. It's not easy. And so oftentimes I've been able to reverse their quote-unquote diagnosis of lupus. Sometimes when they're not getting better, they're not clearing out their infection. And what I've found recently is a lot of these patients actually have mycotoxin overload from maybe a leak in the house. They'll have a roof leak, and they don't even know that they're being exposed. It's not to the mold itself, it's to the mycotoxins that are going through the wall that are produced by that mold. So they're toxins, they're not living organisms, they're just going through the wall, and they're filling up their liver and their brain and their joints. And their immune system, it's overwhelming the immune system. And so the immune system has to fight, and it just can't handle it anymore. And 1/4 of the human population cannot detoxify mold toxins very well, and they need a lot of support. So some of those patients who don't respond to the antibiotics, now I'm starting to check for mold before them, because I noticed that patients who are not correcting their Lyme disease, they have a mold toxicity, and so I'm detoxifying them, or I'm getting them to get out of that house. I have a patient actually recently who had a cancer, because again, when your immune system is overwhelmed, it's gonna, it can only do so much. It's trying to get rid of all the cancer cells that are floating in our body, but this, when it's overwhelmed with whatever toxin, infection, even toxic thoughts and emotion, your immune system just drops. So when that happens, you let things go, infections start to come out. And so I kind of do a whole panel of tests, and so yeah, lupus patients, I feel like in the functional medicine realm, I'm sorry, I didn't mention that I do functional medicine too, which is more looking at the human body and how it can support itself, kind of what you're talking about. You're supporting the immune system to do what it was intended to do, which is get rid of toxins and cancer cells in your body. And so whatever it takes. And so I kind of use those to do that. So lupus actually, it's sometimes not lupus is what I'm saying. Is like there's another reason for that.
Thank you. That's great to know. I'm glad you shared that there. I know somebody personally who was dealing with that, and so it's really, it's great. The next question is, how can we as patients, caregivers, support and encourage the medical staff that's providing care? Do you want to try that one, Nina? Can you hand the mic over to her? There you go.
It's a very kind question. I don't know if anyone's ever asked me that.
Aww.
I think one thing that to remember is always that you are as the patient and the caregiver, you are the one that should be taken care of for sure. We have a lot of great support services within our hospital system and amongst our peers. But I think one good thing to remember, I guess, about us as providers is that we're humans too, and we come to our jobs every day with our own stressors and our own things going on in our lives. And I think just employing some patience is always really appreciated. But don't worry about us. You're the one that we're focused on. But thank you. That's a very good question.
Aw. One of the things that we used to do is we kind of freaked out our oncologist in Arkansas because we would, we're kind of, well, I won't include my wife in the silliness, but I'm a little silly. And so I know oncology, I know all of you guys see, you see heavy things, death and things like that all the time, it's a daily basis. And so one of the things that we decided was to leave our oncologist laughing. So we would do something silly to make sure that he was laughing. So when he went into the next patient, he was going in there with a good mood, in a good mood. So we did bad jokes and dad jokes. Oh, yeah, go ahead.
Okay, coming from the hospice area of medicine, I will say being, as a hospice team, we want to be very communicative, is that right word? With our families. And it's wonderful when they're the same back to us, and not only that, honest with us, with, because I went into homes, and sometimes I was dealing with families and thinking, okay, in order to give the best care that I can give and our team can give, we need to know what's going on in the home and going on with medications, therapies you may be doing. I'm sure that there are some patients that were using marijuana, and they would never tell me because they were kind of embarrassed by it, but it was legal. So I'm like, and we needed to know that information, but when it was withheld, it made it really hard on our part to kind of dial in what needed to be done with the patient, whether what pain medications they were taking or not taking, because managing pain is really important for the hospice patient. And sometimes they'd be using family treatments, to say the least. And so it was just really hard to manage pain when something else was going on the side. So what I'm saying is just honesty with your team that's working with you, because otherwise we can't do our best in order to serve the patient and the family when we don't know necessarily what fully is going on.
Great, thank you. Is Cecilia here? Cecilia Emerson? Are you here? I can't see. Okay. If you are, come on up here. Ladies and gentlemen, Cecilia Emerson. So I wanted her to come up for this next question as well to answer. I know all of you can answer this question, but I know she's going to be talking about this in the next session. So why, the question is phrased, why doesn't the medical field do more to include nutrition as part of care? I know that Dr. Shum, you just talked about that as well, and I know you just talked about that too as well, Dr. Ma. And so, is there a push toward nutrition? Is there a push towards more medical side of things in the sense of medicines and things like that? So, what do you want to answer that one, Dr. Shum, first, or do you want Cecilia?
I'll let ladies
Okay,
Well, thank you.
right ahead. So let me just say, Cecilia, RN, right, with Providence. Is that true? Okay. And also, she does nutrition, and she'll be talking about nutrition right before lunch, just so that we can all make healthy decisions, I guess. And so, Cecilia, go ahead.
Well, thank you so much for that introduction. I just feel that I need to say that my focus has always been metabolic health and mitochondrial health. I mean, just through diet, of course. And so, as such, I just like to think about in the world of cancer. I just like to think about what I'm very practical. So, what cancer likes and what it doesn't like. Well, we know that it likes sugar. It's got insulin receptors. It uses 400 times more sugar than normal cells. And so from a very practical perspective, we can just kind of starve it. And healthy cells, normal body cells, use ketones, whereas very well, they thrive on ketones, where cancer cells don't. They can use them, but not very well. So knowing that information for me, when I found that out, was just mind blowing. So I was like, wow, this is one way to definitely prevent it. Of course, once cancer's already present and, there's a lot of things to consider. There's, it can get very complicated, but that's basically the way I like to think about it, because I'm not a doctor. I'm a nurse. And so, I'm teaching patients very practical things and very practical insights, and that what they put in their mouth does make a difference. So that's right.
Okay.
I think nutrition is so important. The challenge, especially in our area, is I don't think there's enough nutritionists, first and foremost. And the second thing is it's hard to get somebody to pay for it, to be honest with you, is I think the biggest barrier. About 15 years ago, we developed a wellness center because we also believed in a more integrative approach with the standard treatments as well. And I was fortunate enough to have some great nutritionists from PIH who volunteered their time actually. And they would come into the wellness center, and I would try to group patients together just to, maximize time and say, hey, I could get 20, 25 people. And when we started, it was like, she would always tell me, Merrill, there's too many people. They just kept coming because it was so important, but it's hard to find a consultant to say. And she ended up leaving and joining another group. There's private groups like in Pasadena. They pay as a consulting fee. It's very, very expensive, but they're worth it. So how do you balance this challenge of financial toxicity, which we were alluding to earlier, yet still be able to get that much needed help? Because I think nutrition is very, very important. I agree with you.
Yeah, sure.
Sorry. So if you want to, I have a booth in the back. Later on, I can give you, there's a cancer care book, and it does have a nutritional book that it details what kind of cancer you have and what kind of diet you need. So just ask me for it later. Thank you.
That's great. I'll be looking at that one.
I want to say to you,
Sure.
one of my former colleagues is a cancer certified dietitian. So it's kind of like a new wave with dietitians, nutritionists, that there now is a special certification they can get to treat cancer patients and survivors. And she has a wonderful website. It's called cancerdietitian.com. And she actually trains nutritionists in cancer care. And she has a lot of free resources. So like guidelines, recipes, flyers, information. So I'll also be the booth too. So if you want additional resources.
That's great. Thank you. That's awesome. Any recommendation or recommended resources for a patient caregiver to learn more about the human body outside of the doctor's office? Is there any resources that you can think of? Good.
I'm really into long form podcasts, so I'm not sure about you, but my history is that 24 years ago I was just regular trained family medicine. So, but for the past 20 years I've been studying integrative medicine And one of the first doctors that, a conference that I went to at that time, it was called Complementary and Alternative Medicine, was Dr. Mark Hyman. And he does have a pretty decent podcast. And so, yes, and he goes into that in great detail. And so, yeah, I would definitely follow a lot of what he teaches. I do follow a lot of what he teaches, and he's helped written textbooks, and he is he started the first accredited university for integrative medicine or functional medicine, and out of Bastyr University in Seattle. So with Dr. Jeffrey Bland, who's a biochemist who helped pretty much write the textbook on functional medicine. Again, looking at how the body works. And if he's a biochemist, he started out as a toxicologist, studying environmental. So he was an environmentalist looking at how chemicals affect the human body and what to avoid to not get cancer and to not get disease, and how much is a tolerable range of certain toxins that we use, pesticides and all that. And so I guess that he saw that it wasn't really happening in medicine, that there was not a correlation between toxicology and what was actually happening. So he's kind of the father of functional medicine. So he and Dr. Hyman worked very closely together to start that new field, which it's really tough in this environment to get that word out. And it's not standard medicine, unfortunately.
Great, thank you. Is there anybody else that would like to say anything? Okay. So the next question kind of goes along the same lines. So a friend of mine who, when I was going through like major treatments, a friend of mine had like stage 2, very easy treatable cancer. But he didn't want to do traditional, like regular oncology type medicine. Like he didn't want to go to the doctor. He didn't want chemo. He didn't want radiation. He just wanted all natural stuff. So, and his was very treatable to go to he could go to and get surgery or regular, and it probably would have been done. So after doing that for 8 months, he got to the point where his cancer was all over. And then eventually I was called, and he said that, or they said, his family member said that he had gone to be with the Lord. And I almost broke my file cabinet by punching almost a hole in it. I was really upset. So what is the balance between alternative medicines, alternative ways, and the medical side of things? Yeah.
I know you guys are going to have brilliant answers. I'm not going to have. Oops.
I lost you. There you go.
Oh, anyway. Oh, thank you.
There you go.
Okay. So I was just thinking of Dr. Thomas Seyfried. Have you guys heard of him?
Mm-mm.
He's amazing. He has been working. He's a physician, obviously, for many years. I think he's just about retired, and he kind of invented this method called the press pulse method. And what it is you stress out the cancer cells with it's with chemotherapy, radiation, or actually you can start by debulking if it's a tumor, you can start by debulking it, and you can do that through fasting and a ketogenic diet, things that don't feed those cancer cells. Debulk it, and then you can opt for surgery. But this press pulse method is fascinating because what it does is it attacks all the cells, because chemo tends to attack all the cells of the body, right? So you're attacking both the bad cells and the good cells. And then after that, you can use another stressor which is like using ketones for healthy body cells, so that the healthy body cells have what they need to thrive and to recover and to, not die, while the cancer cells are still, having the effects of the chemotherapy and dying, essentially. So there's that it's taking into consideration what your healthy body cells need, as well as how to attack the cancer cells, which I think is kind of the goal of therapy. But his method is called the press pulse method, and there's been a lot of success with that.
Okay.
I think that.
I don't really think I have. No, go ahead.
Well, I think too, I think there's value in both. And I think that it doesn't have to be one or the other that you choose. There's a lot of
Yes.
things that can work in conjunction with one another. And I think as an oncology nurse, like I, gave chemotherapy a lot in my career. And I had a colleague one time say to me, in 50 years, they're going to look at you and say, oh my God, you gave chemo? That's so archaic. There's all these immunotherapies now and alternative treatments that are way better. And things are constantly evolving and changing. And there's so many, both medical and alternative resources that you can use that can help with symptom management and recovery from treatments. But I think ultimately it's good to lay out all of your options and be really educated on, if I go with this route, what will the outcome be? What will my symptoms be and how can I treat those versus, really just being educated because at the end of the day, it's everyone's personal choice too. So it's our job as providers as well to support that. And, some people don't want treatment at all. They want nothing. They just want to live out the rest of their days with no treatment. So just being educated on all of the options you have.
Actually, I'm sorry. I'm going through this, actually recently. My mother-in-law was diagnosed with pretty aggressive breast cancer. According to the two oncologists, she got two opinions. They told her that this is very rare, 1% to 2% of breast cancers, and that is very aggressive. Then you should have started chemo already. Initially, she's 76, I believe, and she stated that she. At first, she's like, I don't want surgery. I don't want chemo. I don't want anything. And, I told her, it's her decision. That's kind of where I align all my patients. I always give them that decision, and at first she said she didn't want surgery. So I said, that's fine. But I do feel that there's so many things you can do because again, I'm I'm integrative. I don't give chemotherapy because I'm not an oncologist, but although I have plenty of patients who I've sent for oncologists and chemo and all of that, but it was her decision. And then she decided on surgery. Later, she got a lot of pressure from family in Mexico, and she lives in Mexico, and they made her get the surgery. So she got it, but they wanted to start chemo right away. She's like, no, I don't want to chemo. So brought her here for a second opinion. They said the same thing. She needs chemo right away. I'm just looking at the prognosis for her. I never mentioned really the prognosis to her. I just said it's pretty aggressive. It wasn't much difference, as far as length of prognosis. So she doesn't tolerate medications very well. Like not even like Tylenol. She just has side effects to every medication she tries. So she decided not to. And so I have every integrative thing possibly she's on. Right now she's loving it, and she has never felt better in her entire life. Like before she even had cancer, she's like has so much energy, and she had lymph nodes. All her lymph nodes were almost all of them were positive. She had a huge lymph node, and it's shrunk and it's gone. She's already past her prognosis at this point now, so she's feeling great. We just know that no matter what, God, she's a pastor herself, so she knows if she passes, she's with Jesus. If she's here, she's with Jesus. She's full of joy now, and I mean that's her choice again. But I've had many patients whose choice was oncology, and that was awesome, and I'm supporting all of them there too. And we have a lot of patients I integrate and I support that. So a lot of times if you do use some integrative techniques, you can reduce the side effects from chemo and you can help them tolerate it much better. And sometimes they can use lower dose chemo. So.
Yeah, so the honest truth is that we're all unfortunately a little biased, and there probably is some merit for everything to be integrative. Unfortunately, all of us subspecialize so much that we kind of only know what we know, and it's really hard to put those together. Going back to your friend who's a stage 2, anything for me would have been very clear cut to remove it.
Yep.
And you remove it early enough. So the question is, was there a confusion about someone recommending chemo or radiation that probably wasn't even needed? Just doing the surgery, it would have been done. But we can't go backwards. And to her point about her mother, it's a personal choice.
Yeah.
So again, as a medical oncologist, we like to present options and then feel what the patient is feeling that he or she would like to do and kind of support them. Unfortunately, we don't have a lot of data, or I'm not very familiar with the data for the integrative medicine. And so some of the items that are offered sometimes could interact potentially with our drugs, and we just don't know because our trials, from an oncology standpoint, weren't run with it. And so could there be merit? Could it be safe on it by itself? Yes. But with some of our newer drugs, how does it interact? I don't know. And so that's the challenge that we're almost like have to be very upfront with our patients. They say, hey, doc, I have a friend who's taking this vitamin or doing this therapy that's a little bit integrative alternative. And I have to be frank with them, just say, I just don't know how it interacts with my chemo or my immunotherapy. And so I try not to overlap it. I'll give you an example. We had a patient who was on immunotherapy doing anti-parasites because they're worried about building their immune system. We didn't say anything. And patients has liver failure, and everyone's scratching their head, and it's been months. And it's like, what's going on? Dug into history, but it's safe by itself in some arenas, but now you're putting the two together. So I've had patients who talk about alkalinizing the blood, and she probably knows a lot about it as well. But if you do too much of it, I've had patients going to renal failure and going to heart failure where I've admit them. And so you have to always try to take a step back and put it all together, so it's very challenging. Because as a medical oncologist, we don't have all the extensive nutritional background as well as some of the integrative approaches that are out there to understand the interaction.
They're playing the music. Oh, they stopped. I can go on forever now. And then they put it back on. That's great. So real quick, we're going to take a break here in just a minute. But what I just wanted to say is that what I've always told people is that you stand, and basically what you guys are saying as well, but you stand before the Lord and you have to ask the Lord what he wants you to do. Because one of the things that's constant with all cancer patients is there is not a lack of someone to tell you what to do. All the time. It's drink this water, take this, stop eating that, do that. And it's all conflictive. And you're like going, what do I do? What do I do? Like the patient, you said the 100-year-old patient, it's like, wow, what they can tolerate, what they can't. It's a lot of times it has to do with how, in my estimation, is how you're following what God has told you to do, and then that's what you need to do. And it also, if you're not a Christian or if you're not a religious person, then it's that decision that you have to make that just says this is the direction, and then you just own it, at that point. But try not to be pig-headed in a sense. So